Good afternoon. I am Dr. Bill Bird. I'm the Chief Medical Officer here at CGH Medical Center, and
Sandy Westbow, one of the infection control nurses here.
this is our 5th week talking to you about COVID-19 and what's going on with that here at CGH in the community, and to take on some of your questions that you have as well. If you'll notice, can they see the pen?
Yes.
Okay, this pen is where I start going like this, so this pen is my marker, so I'm going to try to hold myself to not flail my arms beyond this pen. I probably should move a little more that way. Okay, so with those little kind of ground rules in place, what do you say, Sandy? Let's kick off some of these questions. Okay? Let's see here. Can you talk about contact tracing testing and its importance? I have that one too, but these are some of the other ones we had previously.
Sure, I can take that one.
Yeah.
So contact tracing is something that's been used in public health for many, many, many years. Patients who have any kind of infectious condition that could be spread from one person to another, what the health department does is they get in touch with the person that has the infection, and then they find out who they've been around recently. And then they'll interview those people, and the circle can broaden wider than that based on whether or not those contacts to the infected individual has symptoms of disease. So they're using that obviously in coronavirus. If you had contact with someone who was positive, you'd get a phone call from public health, and they would follow up with you.
Thanks, Sandy. And that contact tracing, if I were in a perfect world, that contact tracing would just be part of what we would have in place to try to do a better job of identifying, quarantining folks who have COVID and keeping them quarantined until their quarantine can be lifted, and keeping others maybe not as quarantined. And so I'll give you an example. I was like the governor of California. So he had, I don't know if it's a he or she, to be honest with you, but the governor of California had like 6 steps that would be helpful to ease some of the restrictions that they have. And one of those would be expanded testing, which is obviously true here in the state of Illinois. We do not have access to all the testing that we want to do. We do not. We are still in a mode of testing people that are going to be hospitalized, people who are healthcare workers, people that work in institutional settings like nursing homes, prisons. That's who we're testing, and we're getting results back quickly on those folks. But we still can't do just as much testing as we wanted to do, and we would love to do testing on everyone who has respiratory symptoms right now. Because when we could find, if we did that we could get those folks who are positive, and we have this whole process of what we were just talking about. I'm going to find it here. Yeah, so this whole idea of contact tracing would be another part of that. So if you had someone who was positive, then you would say, hey, we need you to quarantine, and by the way, who we've been around, do they have symptoms? And maybe even if they don't, we test them. And then anyone who's positive, then folks from like the health department, and you'd have to have the personnel to do this, but they would kind of be checking in on those homes to make sure things are going well, to make sure that they're following with those restrictions. That would be great. And then the other side of this would be, it would be great to have what's called antibody testing or serological testing, which is a test that allows, after you've been infected, to check and see if you, or if you didn't even know if you were infected, but a chance just to see if you've developed some opportunity or a chance of immunity to this infection. So that also is something that is not readily available right now for us. Those are the kind of things, if we had those in place, would be, I think, a lot easier for the folks at the state and federal level to be able to ease restrictions. Any other comments about that, Sandy?
Yeah, just one thing. In the risk categories that you talked about are priorities for testing. That's not to say if you contact your physician and you don't fall in one of those categories, you may be sent to our Ready Care area and still tested, so it's not just those people that we're testing. It's just those other people, sometimes it takes a little bit longer for the test result to
Yeah,
come back.
and we're doing it very sparingly on those other folks, just so you know. I don't want to set any expectation that you show up to Ready Care and you're going to be tested. Because we just can't do that. We just don't have that to be done. Speaking of which, testing. So, let me see here. Numbers for this week. We've done 425 tests here at CGH. 376 have been negative. 21 have been positive. Here's the good news, is that I was looking at last Thursday what our numbers were, and we had done 358 tests. We had 321 negative, and we had 20 positive. So our positive number, at least here at the hospital, has only gone up by one patient, which is awesome. That's a great thing. We're not seeing exponential growth. So the work that all of you are doing on this idea of social or physical distancing, I think is helping. I know it's helping. Now we know in the county there's more cases than the 21 that we have here, because folks go to other places besides the hospital to have testing done. But nonetheless, I think this is a good trend. Thoughts on that, Sandy?
We hope that, again, that you will pay attention to the distancing until things open back up a little bit, so that we can continue on this trend in the near future.
Yeah. I got off a call from the Illinois Department of Public Health today, and kind of for some hospital folks, and I just wanted to share this with you as well. Another couple pieces of good news. So there's been a slight increase in the number of hospital beds needed in the last 3 days in Illinois, and particularly the southwest, northeast, and west suburbs along with Chicago. However, if you look at where we're at in terms of numbers, in terms of hospital usage, we're still, it's not this really quick upward type of trend. It's if anything, just seems to be just like that, and we're hopeful that it will begin to kind of go that direction. It hasn't quite done that yet, but all signs point to it being pretty close. Of note, in Illinois right now, there are 4,400 people in hospital beds who are patients who have COVID or there's suspicion that they might have COVID, and they're using 66% of the ICU beds in our state, and 60% of the ventilators. The state of Illinois is doing 5,000 to 8,000. Well, not the state of Illinois, but within the people for the state of Illinois, there's about 5,000 to 8,000 tests a day being done. That sounds like a lot, I know, but it's not nearly enough. And the number that number, I've been looking at that. You probably have too, Sandy. That the state reports, that's been pretty stable for the last week or so. So it's kind of like we've maxed out how many tests between private and public we can do for state of Illinois residents. And until we can get more capacity, that's kind of where we're going to be at it looks like for, I don't know, maybe at least until we talk next week. We'll see. Other thoughts on that, Sandy?
Nope.
Okay. Let's see. There's since our here you go. Here's the question for you, Sandy. Since our small town COVID spread is slower than heavier populated areas, would that also translate into the virus lingering here longer because of less herd immunity?
It would be good if we knew the answer to that question. You would think that that's a possibility, but because, again, we're unable to test for antibodies in people to see if we've had a large number of asymptomatic or mildly symptomatic, you simply can't know that. It stands to reason that in heavier populated areas there would be more transmission because there are more exposures, but we're not going to really know that at this point. There's speculation about a second wave. We've heard different months, but we don't really know that yet.
Okay, thank you. Let's see, what other questions? Would it will it be prudent for schools to resume this school year from a medical perspective specifically?
Yeah, I don't want to touch that one. That's a governor's call in the entire state. So
Yeah.
I know that there's a map that you can pull up if you Google it of which states already have canceled for the entire year, and there are more and more. So I think the crystal ball says that's looking less and less likely that they will reopen this year.
Yeah, I will. Yeah, I don't have an answer for that in terms of would it be prudent or not. Really, and I applaud the governor, at least from what I'm seeing on the press releases. He's relying on people that are epidemiologists. I didn't say that right. Anyhow, people that look at these numbers and population trends and get some sense of where this virus is heading towards and what strategies we can use to mitigate that. And I think that's what's going to drive this. Is that fair to say?
I think the prudent thing medically for opening up the state is to be in a kind of a phase in. You don't want to just open every business, school, group event, because we'll be right back where we were afraid we would be. So, obviously they'll have to take that into consideration when they
Sure.
come out with the plan.
Sure. And just as a general rule, as a physician, my perspective has been that like a lot of things spread very nicely if you have school in session. So when school's in session, all bets are off in terms of like the flu or people getting a bunch of colds or all these kind of things or GI bugs. So from a medical standpoint, it probably makes sense, unless we're absolutely sure that we're going to be good to go, that these other things that Sandy's talking about phasing in first, that we would do those things first before we would do a school, just because every kiddo that goes to school then comes home and there's all that back and forth and all the opportunity for transmission of the virus.
Children share their germs.
We're not even great at like social distancing, and we're not really great about not touching our faces and stuff, but as you all know, little people have no sense of that. And even people that are grade school, junior high, even high school, sometimes there's less a sense of that than there is in other populations. Okay. Let's see. There have been some questions about the tent that we have outside of our emergency department. So we received a tent from Illinois Emergency Management. Yeah, last Wednesday, and then kind of got it together, and it went operational this past Saturday. Sandy, do you want to talk a little bit about that tent?
Well, the specific question that we got, and then we can expand on that, is why are the tents only open 8 hours a day? The tent is open from 11 to 7 because those are the hours when our emergency room generally peaks, or that's the busiest time for the emergency department. And the goal of the tent here and other facilities that have them is if we would start to get an influx of patients that would overwhelm the emergency department, that we would be able to utilize that. So we took a look at what our kind of prime time was.
Right, and be up front with you, I mean, so far the tent has not been busy at all. We have not had very much in the single digits in terms of number of folks who, I think since we've had the tent up, that have utilized it. So it's not been utilized much at all, which is great. That means that it kind of fits with this whole, we have 21 positives now, we had 20 positives last week when we spoke. And people are, and I think those of you who are listening to this, as well as others, have a pretty acclimated and a pretty good understanding that if you come to us and you have respiratory symptoms, if you're stable and if you're breathing fine and if your vitals are good, we're going to say, we're so glad for that. You might have COVID. I need you to go back home and we need you to quarantine, and we'll tell you how long we need you to do that for. So I think the fact that we don't have any, we wouldn't be doing just routine testing on anyone who shows up to that tent or Ready Care or anywhere else, I think also is driving the fact that those numbers are not very high. But yeah, I think there's been some concern that tent means that then there's been this surge in surge of new cases and that the number of sick people in our community is, we needed to bring that tent in because of that. That's not the case. We planned this tent, was it a couple weeks even before it showed up? It was just an opportunity we had, and we didn't know where we would be at in terms of how many cases we would have, and it made sense for us to have the tent. So right now we have the tent. I would say it's probably a week-by-week basis in terms of whether we continue to need the tent. And so, yeah, it's a good thing to have, but for those of you out there who may have told yourself stories about the tent being there for some not so good reason, it's good. It's just there just in case. So let's see here. What next question do we have? Where do you go if it's not regarding the coronavirus? So and it says you would catch the coronavirus if you're exposed to others that have it. So yeah, it's a good question. And so what we're still encouraging folks to do is that if you have symptoms and you think you have a bladder infection, or you rolled your ankle and you want to make sure you didn't break your ankle, or any of a number of things that can go on during the course of our lives, reach out to your primary care physician and give them a call and tell them what's going on. And they are doing a really good job of deciding whether or not your symptoms are a good fit to come to their office. They also are doing televisits, so there may be a time when you have a call to the physician's office and they'd say, you know what, I think the doctor would like to do a televisit with you. And yeah, sometimes they may send you to Ready Care or the emergency department. But your first step is to give your primary care physician a call and go from there. Whatever the medical situation you have going on that you want to have addressed. You have another question, Sandy?
There is one. I'm going to pump this one to you. Has any CGH provider tested positive?
Yeah, I don't know that we're really going to be going down that path. I kind of like to keep that. I like to keep that. At least right now, my thought is that would be more of a confidential thing for that provider. And
we don't tell you where the people who test positive work. We don't give out any kind of information that could help identify the individual. So.
Yeah. Next question.
See, do people go to ED for maternity? Not really positive exactly what you're asking, but the process for maternity patients hasn't changed.
It is not, and just so you know, in the ED, we have two areas of the ED now. We have an area where the patients who have suspect COVID that we have them be in, and that's kind of walled off from the rest of the emergency department. And so if you were someone who was in labor, the same process that has applied in the past would occur. And I'm pretty sure what that is you go to ED registration, and they just send you up to the third floor, and then you begin your process there with the OB floor. So that's the same. Other questions, Sandy?
So I think we kind of covered this one. Where are we supposed to go for minor things like a script or just a nebulizer treatment? Again, you contact your provider for those questions.
Yeah. Let's see here. What is the CDC saying about homemade face masks?
I'm thinking that we kind of covered that last week when they came out with their recommendation. If you pull up their website, I think we posted that actually on our coronavirus page. It even shows you how to make the face mask.
So if you didn't happen to listen last week, what would be
I'd say go to our page and it explains the entire process. I'm promoting our wonderful people at the marketing department.
Yeah, I will say that the CDC is supportive of properly put together homemade face mask, and I'm very supportive of it too. Because if you have a face mask that you've made on your own, that's one that we don't have to use from our own supply. So very much appreciative for those of you who either make those or know someone who makes them and then use those when you go out and about in public. I know that the recommendations are more and more that when you're out in public, if you're going to be somewhere that you're going to be close to, you're not going to be able to social distance very well, that it would be a good idea to wear that homemade face mask covering. I think I feel pretty comfortable telling you that's a good idea to do. If you're going to be able to be 6 foot or more apart from folks, I don't think you need to. But if you aren't, yeah, I think that's a good thing. It can help protect other people. If you happen to have it, you could potentially spread it. Oh, what else do we have on the docket here? I'll make sure I have some of the ones that already came here I didn't forget about.
Do you have to have a doctor's referral to get tested for COVID-19?
No, but what you do need to do is when you go to ReadyCare, you go to our ED, you're going to have an evaluation by the nurse practitioner or physician, and they will determine based upon your symptoms and your risk factors and those things we've been talking about whether or not you're fit to get the test or not. So you may go there and let's just say this, right now, I'd love to be in a spot where we could say this, but right now we're not in a position where you could show up and say, yeah, I'd like that test. Could you just go ahead and do it for me? Unfortunately, we're just not able to do that right now. And I'm going to digress a little bit from the questions. And I read this the other day, and I thought it was really interesting about this, where we're at right now as a country in terms of testing and why we are at where we are at as in regards to that testing. Because we know that if we had widespread testing, it would make things so much easier in terms of mitigating and understanding who has the infection and quarantine, everything that goes with that. So January 31st is when President Trump declared a public health emergency in regards to COVID. However, from January 31st until February 29th, only the CDC could conduct testing. And that was like 12, there's only 12 places in the country that did that testing up until February 29th. And it wasn't until February 29th that private labs and hospitals were allowed to develop and use diagnostic tests. So you had a 1 month lag in terms of when the disease was really starting to show up in your Seattles and even starting in your New Yorks and those kind of places until the private sector could begin to really ramp up and develop and or ramp up, if they already had a test, ramp up that production. So that month is like that's the difference between, like, for us, about a month ago is when Sandy and I started talking with you. So it was March 14th that we had our for CGH had our first positive case of that someone tested positive for COVID. So if we were where we're at right now, where we're going to be at a month from now, if we were there now, and in other words, if we could set the clock back a month and we had that month back where nothing happened from the standpoint of allowing private places to get this going, I know Monday morning quarterbacking is pretty dangerous, but I'm just saying that we'd be in a different place in terms of our testing capacity and what we could be able to do right now. It would take 750,000 tests a week, not including in major outbreak areas, to do all the testing we needed to do to test everyone we needed to test who potentially could have COVID in our country right now. We don't have that. And to give you an example, and particularly these public labs, the state labs, they just weren't designed, and I'm sure they will be in the future, but they haven't been designed to do multiple thousands of tests. For example, New Jersey State Lab is able to do, at least at the beginning of this, 70 tests a day. New York, the epicenter of this, their state lab can do 1,000 tests a day. Pennsylvania, Alabama, 300 tests a day. So 85% of the testing that's done right now is done by private companies, not by public, state, federal kind of testing, just to give you some sense of that. So, yeah. I thought that was interesting, just in that it's that's part of where we're at right now, and that's part of why we're at where we're at, but we're making progress, and I feel good about at least the number of cases we've had here in the area. Other questions, Sandy?
How common are GI symptoms with COVID-19?
Gosh, got a number for that?
I don't have a number.
I don't have
how
a number for it,
common they
too.
are.
Yeah.
diarrhea is one of the things that's listed on the form that the CDC has where they ask people what their symptoms are. So that is one of the symptoms that you can have with the virus.
Mm-hmm. It is, and I will tell you that if you show up to our emergency department or Ready Care and you have GI symptoms, we definitely would not. We would take those seriously. And if you're admitted to the hospital with GI type symptoms, we're going to be testing you for COVID and having you in one of our COVID units until you've tested negative. So we are taking that symptom very seriously, in addition to the respiratory ones that people might show up with.
This is kind of related to that. How soon do the GI symptoms advance to other symptoms such as respiratory, etc.? It's not that the GI symptoms advance to respiratory symptoms, and one individual may only have GI symptoms, so you don't necessarily have all of those. Generally, the respiratory symptoms as they get worse is what brings people into the hospital, but not everyone gets a pneumonia or a severe respiratory infection.
I've read where if you do have like diarrhea or GI symptoms and you do end up getting admitted to the hospital, there is a tendency for those patients to get sicker, but it's not a one-for-one correlation.
Does CGH have enough ventilators?
Right now we do. We're in good shape. We've not had to go beyond our normal supply of ventilators to take care of patients here at CGH since this outbreak began.
Thank you for keeping us updated. I hope you all at CGH are still happy, healthy, and safe. I don't know about happy.
Oh, yeah, we are. Why wouldn't we be happy?
Healthy and safe. We're all healthy or we couldn't be here. We're all screened every day that we come here, and we feel like we're very safe.
Yeah, I feel good about that too. I wanted to share something else too. I don't know if it's a question that's come up that Rebecca's writing down or not, but we definitely hear almost on a daily basis from our medical staff, from our other staff, from patients, from families, from you and the public about, hey, there's these really quick tests that you can do really quickly. Why don't we have those really quick tests, both for checking for positive or negative, or the quick tests that check for whether you have the antibodies and that you've been exposed to COVID in the past. I want to give you a little information about that. So, first of all, according to the World Health Organization, or WHO, as they say in the biz, right now, the WHO is, and you know, it's like the WHO, and then they're the international, and you have the CDC and IDPH. And the WHO is, right now, their position is that this point of care rapid testing for antigens and antibodies, as well as the quick tests, that those should be being done right now still in research kind of facilities rather than the community type hospital situation where we're at. So I'm not saying that there aren't institutions that aren't doing that kind of stuff, but at least right now, from the data, and we're trying to be driven by data and by science, from the data that we're seeing right now, I don't think first of all, it's hard to get those tests, and second of all, I don't think right now it's a fit here at CGH. Now that may change by the time I'm talking with you next week, but at least as we sit here and I speak and I'm talking to you and Sandy's talking to you right now, that's where that situation is at. And speaking of those antibody tests, so there are 90 of those on the market right now. 90, count them. Right now, I think this morning now there are 3 that have been approved by the FDA. So that means there are 87 of those tests floating out there right now that they may end up being okay, but boy, they haven't even gone through the minimum inspection from the FDA in terms of emergency allowing them to be used. So as I talk to our doctor, our pathologist, our physicians who are skilled in laboratory work, and I talk to our medical technologists who run our laboratory department, right now I think where we're at is a good spot, And I guarantee you, every day they are scouring and looking to see if that's a possibility for us. The one place that was FDA approved, we made a call, just so you know, we reached out to a couple different ways, and so far we haven't heard much back. So they have, to be honest with you, bigger fish to fry right now than our community hospital. It's probably the New Yorks and Detroits and Chicagos that are getting the traction on some of those tests. Okay.
So on those tests, just again, be aware that they're not FDA approved. And now the FDA, because there are so many companies that are advertising those, is taking another look at those tests. I would say to you that if you are going to go for that testing, buyer beware, because you may get a false sense of security. If you get a negative result, it may not be accurate. So the first question I would ask that facility that you're going to is if that test that they're using, is it FDA approved?
Yep. Because you got to remember, if you do one of those tests and we've talked about this before, but sensitivity and specificity. In other words, if you can count on the positive being positive and the negative being negative, then that's all well and good. But if you can't, and you're making decisions, or other people are making decisions about how to go about taking care of you or taking care of those around you, not good. So that's why laboratory and all this testing is so important, and getting it right is so important. So, like I said, by the time we talk next week, the ability to have the really dependable stuff may have changed, but that's not where we're at, and that's not where we're comfortable being at right now. What else do you have, Sandy?
Is May 1st still the predicted date to start doing non-emergent surgeries? And we don't know the answer to that yet either, but we're, as a group, at least in the hospital, starting to talk amongst us and how that's going to be rolled out if and when we start to do that. We're waiting for some direction from the governor in terms of after April 30th, are we opening anything up? So we don't really have an answer 100% on that yet.
The answer, right, from my perspective, is May 1st the day that we begin to open things up? Yes. Unless, another way of saying it is yes, unless the governor has other plans. And I fully anticipate in the next few days, I've got to think he's going to come out with what the deal is, because we're not unique. We are well into planning for what it's going to look like come May 1st, if the governor gives the go-ahead to have some things begin to happen again. Because that's really important to our patients, it's really important to our staff and everyone to get back and get up to speed whenever it makes sense to do that. So we're planning for it. We fully understand, though, that those plans may change if the governor has something else to say about that. I understand that the president was going to be making some type of announcement today about the country opening up as well. Understanding, of course, that the president has things to say, and then individual governors have things to say as well. So we're waiting, just like the rest of you probably are waiting on that as well.
I'm not sure we can answer these two questions.
Okay.
How many COVID-19 cases are in your hospital, and how many deaths?
In the county, there have been, I think the county number is 3?
3 deaths.
Yeah, I feel comfortable saying that. And then what was the other one?
How many cases in our hospital?
Yeah, so we've had that question, it seems like about every week, and I respect the curiosity on that part of things, but we don't typically go into detail about how many patients have or don't have. What I can tell you is that since this began, we definitely have had patients who are either persons under suspicion of having COVID or having COVID that we're taking care of here at the hospital. And we have particular areas, both in the ICU as well as on the regular second floor and emergency department, where we have areas where we can safely take care of those patients. And yeah, so we have those things in place, and we've been doing that, and we'll continue to do that for the foreseeable future.
How do we compare with our neighboring counties? Iowa excluded. I don't have exact numbers. Lee County has less cases than we do, And Ogle, I think, is pretty similar to where we're at, but the other counties, I don't have
Yeah.
numbers off the top of my head.
I think I just looked before I came. Lee had 15 cases. Henry had, I think they had, anyhow,
I don't know
yeah.
very many.
They had some, and yeah. I'm sorry, I'm not very helpful. I know our numbers in
Yeah.
the 30s, and
At 2:30, those numbers will change
yeah.
as the governor releases the numbers for today.
Yeah, and if
So-
if you're all interested, it's the Illinois Department of Public Health website. Very nice, very well done. And you hit Corona 2019, and it'll pull up information about all those kind of things.
Mhm.
You can hit different counties and see what counties have what number of positives, and just understand, of course, that there's always a lag from the actual number. Can lag a couple days just because of the reporting process.
Do you know when laid off employees will be able to return? You know, again, similar to the May 1, if nothing changes, we would start to phase in bringing employees back to work, if nothing changes.
Yeah, I agree. As soon as we possibly can, we want to get folks that aren't working back working. So that's definitely the plan as soon as we can do that. And I hope that's May 1st. But we don't have any guarantees, unfortunately. Okay, what else? How long before we can see Tylenol on the shelves?
I didn't know we weren't seeing it on the
I
shelves.
did not know that. Hey, I'm guessing this it's taken up as well, but acetaminophen is of course the generic for Tylenol. ACET. Aceto. Let's see. I think it's ACET. Oh boy. Those start with those, and then it's Minofin. But anyhow, yeah, that's another option. That's generic. And I will say that I've seen some data on the ibuprofens, Advils of the world, which is in that NSAID category, where at first there was a lot of talk about, boy, don't take any of that because of the concern with this infection. I think there's still a little bit of concern, but not as much as there was. So just for what it's worth, I'm with you. If I had to, and I had symptoms, I probably would start with Tylenol. But if I'm in a pinch, I guess I would use a little bit of ibuprofen or Aleve or something like that if I had to. Okay, nice tie, Dr. Bird. Well, it is Bow Tie Thursday, so every Thursday I wear a bow tie. It just so happens that this is when we do our talks. And I shout out to my wife because she picks my bow ties, so thanks, Dawn. All right, is it true? They have a new method of testing. All patients need to do is spit in a cup instead of a swab. Yep, I'm reading about that. I'm reading about that has been approved, and I think they just spit in a cup and then turn that in. I don't know. Once again, Sandy, do you know more details about?
I don't know when.
Yeah.
That
So
would be
it
available.
seems like our experience is that the people who are reporting these things and reporting about these things and when these things are available, and actually when a community hospital like CGH can get access to them, there's a window, and it seems like it's a pretty sizable one, and in that sizable so there's a pretty sizable gap between when reporters say this is available, this is a test that you can do, and then we can get it. But yeah, I wouldn't be surprised at some point in time if we have access to that as well.
It's a three-pronged question.
Oh boy. Okay. When the virus enters the body, does it attack the lungs first? Does it hinder the capacity of the lungs to expand? Does it immediately enter the bloodstream? So my understanding of how this works is that the virus gets into your mucous membrane first. Your mucous membrane. So mucous membranes being like your nose, your mouth, your eyes. That's kind of the main conduit. And when it gets into those mucous membranes, then it gets into there and then can get access to the bloodstream. And then it begins to replicate. And then once it gets in the bloodstream and begins replicating, then it goes to all kinds of different places in our bodies, and that's what gives us our symptoms. That's why some people get the diarrhea the question that Sandy was answering. That's why some people get cold-like symptoms. That's why some people get fevers and chills. So it goes, yeah, anywhere your blood will go, the virus will go. Now, as far as the lungs go, it does appear that the biggest concern here is that this virus causes a viral pneumonia. And so that viral pneumonia takes the airspace that we normally have, that we have probably, if not millions, at least thousands of these little bitty pockets called alveoli in our lungs, and it causes damage to them. And those alveoli are what allow us to take in oxygen, the 21% oxygen that's in the room here. I get to breathe that in, and that goes through that membrane in the alveoli. And so the virus affects that lining and causes the oxygenation to not be as good. And when your oxygenation is not as good, that's when you start having a hard time breathing. You compensate by breathing more rapidly. And sometimes that could even lead to where you hear about people needing to be on ventilators. And the other part of this disease that I am not as well versed on in terms of the biochemistry of it, but I will say that some patients have what's called a cytokine storm, which is basically your body is trying to fix itself, but in the process of trying to fix itself, it's hurting itself. And literally you get like just extra fluid that fills your lungs that are these cytokines, and that extra fluid is just fluid that you can't get oxygen through to your body to be able to breathe well. And for a lot of people, that is the thing that ultimately can cause their demise. Now, there are some people that have cardiac arrest because it seems to have, for some people in the later stages, to cause the heart muscle to not work as well or to have arrhythmias. But those two systems, heart and lungs, are the ones that eventually, for those people who succumb to this, that's the reason. Sandy, anything else you would add to that?
No, but you triggered something when you talked about the cold. So the testing again, I just want to go back to, there is one of the tests that's out there now that is testing for antibodies, but it isn't testing just for coronavirus COVID-19.
Oh, that's a good point.
So on this test that's being offered and around our area right now, if you test positive on that test, it could be that you had a common cold. So it's not discerning between what coronavirus. So again, you need to be aware of what you're being tested for.
Yeah, that's why this is called COVID-19, because there are 18 other coronaviruses, of which the common cold is one of them. So yes, those tests, they're not as discriminatory. Great point, Sandy. For COVID-19, you can go, I'm good. I had it. Well, you've had a cold. And now you're going to go out and so
false
that's
sense of security.
Yeah. A couple of medical things that are happening on the COVID-19 front. I'm starting to read where they're saying that maybe ventilating people earlier is not necessarily what we have to do. And so what they're seeing in this disease is that what typically would be a time when you would ventilate someone and breathe for them, because their oxygen levels go down. Other parts of how when they evaluate those patients, some of them don't seem to be breathing rapidly and seem to otherwise be reasonably comfortable. And so they're learning in these bigger areas where they've had more outbreaks, they're backing away from right away ventilating everyone just because their oxygen level gets a little low. Other thing that's becoming more front and center is that when they make patients prone in terms of their positioning, they tend to do better. And so I do think there's going to be a trend in terms of treating patients. So prone, supine is, do you want to demonstrate that, Sandy?
No.
Okay, I will. Supine is like if you're kind of laying back on your recliner, right? That's just, or you're laying flat on your back, that's supine. Prone is if you're face first. If you're someone who sleeps on your face on your pillow, you sleep prone, all right? And being prone opens up your airway better and allows people to breathe better without having to intubate them and have a ventilator in some situations. So that's what some of the stuff that the medical community is learning as time goes by. And I just read a study that, there's definitely some some hope about an anti-malarial medication called chloroquine or hydroxychloroquine, that was helpful. I'm not so sure now. It seems to be trending down a bit. They've done some studies with some patients, at least on higher dosages of that, and those actually those patients did less well. So we'll see. I don't know, but we're definitely in the medical community learning as time goes by about what the best way to treat these patients is. Anything else for me, Sandy?
No.
Okay. So hey, I want to thank, as always, those of you who are listening to us and are going to listen to us. I'd like to thank those of you in the community who are doing a good job of doing social distancing and continuing to follow through with that. I know that's not easy to do. That takes work to do that. And so thank you for that. And thank you for helping to keep our community safer and healthier. It helps us here at the hospital. We really appreciate that. I want to thank you. I want to thank our hospital employees and the work they're doing to take care of our patients and to keep them safe. And they're doing a good job with each other, keeping each other safe in terms of making sure they do put on their protective equipment properly. I'd like to thank Sandy for the work that she and Gina do on an infection prevention standpoint, and their team. They do really good work in trying to keep us updated on what the latest and greatest is and what we need to help to guide us in how we go forward. I'd like to thank our medical staff, because our medical staff has been really helpful during this period of time of giving us guidance and also being actively involved and supportive in trying to make this hospital the best place it can be. They always do, but even more so now. I've seen them step up, so thank you to our medical staff. I'd like to also, Sandy, I think right now you may or may not be here next week.
I won't be here next week.
She won't be here next week, so we'll be here. I will be here next week. I'd like to thank Sandy for these 5 weeks. I'd like to say they're the 5 best weeks of my life, but not necessarily.
They went by pretty fast.
Yeah, but thanks to Sandy. Well, I'm leaning towards that we may have like guests that I'll bring on, and more about that coming up on our Facebook page, and you'll learn more about what we're going to be having going forward in terms of updates on COVID here at the hospital, which we'll continue to do, and then probably break off from that with some other things that we're doing and related to COVID. So yeah, thank you for listening in, and hope you have a great week, and we'll see you next Thursday. Thank you.